Good afternoon, everybody. Welcome to everybody in attendance and online. I'm Ruth McEwen, and I'm lead member for Education and Public Health. So welcome to the meeting today, and also Happy New Year to everybody if I haven't seen you. I'm just going to start the meeting with the usual announcement. So I would like to inform everybody present that this meeting will be recorded and broadcast live in Microsoft Teams, and then will be uploaded and available for repeat viewing on the Council's website. You should be aware that the Council is a data controller under the Data Protection Act. Data collected during a webcast will be retained in accordance with the Council's published policy. I'm afraid that due to current technical limits in the Council chamber, not all the members of the board physically present will necessarily be able to be seen on camera, but you should be able to hear everyone if they use the microphones. The seating in the public gallery will not be filmed. Members of the public are only able to speak if they've submitted a formal question in accordance with Council procedure rules. Please could councillors, officers and partners attending introduce themselves before they speak at the meeting for the benefit of the public. And just to help me manage the meeting, if any members of the board attending online wish to speak during the meeting, please can you indicate your wish to speak by raising an electronic hand in Teams. Those present in the chamber can indicate their wish to speak by raising a physical hand as usual. And also, can I ask, when not speaking, all online attendees should put their microphones on mute and switch their cameras off. If called to speak, please switch on your camera and unmute your microphone and pause for about 3 seconds to allow for a slight time delay in connection. Thank you very much. So if we continue with the agenda. So agenda item 1, declarations of interest. Do we have any declarations of interest? Nope. Okay, thank you. And agenda item 2, the minutes of the meeting held on the 6th of October. Is everybody happy with the minutes? Previous minutes? Brilliant, thank you. And agenda item 3, questions. And we do have a few questions today, which is good to see. So if I can invite question 1 is David Maynard. Ask a question. Is David here today?
Chair, it doesn't look as though he has come, no.
Okay.
That there are copies of the questions at the back of the meeting room, and I'll put them on online later on.
Thank you, Nikki. If we move on then to question 2, which is Tom Lake. Thank you, Tom.
Well, so just to say, I'm reading my question, recent publicity regarding Coventry's advances in health equality have pointed to the possibility of becoming a Marmot town through collaboration with the Institute of Health Equality, I think, actually led by Sir Michael Marmot at University College London. Will the board consider this approach to tackling health inequality?
Thank you for your question, Mr. Lake. The Institute of Health Equity at University College London facilitates the Marmot Places scheme. This builds upon earlier formats and strategic public health initiatives such as Healthy Cities. There are now over 40 local authorities in England and Wales who've become a network of the Marmot Places. These include Coventry, Greater Manchester and others where programmes of work have begun that seek to implement the 6 policy objectives recommended first by the Marmot Review in 2010 and in milestone reports since then. These have become Marmot Principles, evidence-based action that will reduce the social gradient in health. 1, give every child the best start in life. 2, enable all children, young people and adults to maximise their capabilities and have control over their lives. 3, create fair employment and good work for all. 4, ensure a healthy standard of living for all. 5, create and develop healthy and sustainable places and communities. And 6, strengthen the role and impact of ill health prevention. They recognise that the social economic determinants of health are beyond the health service, and these are the prevention measures which will lead to the best and healthiest outcomes for everyone. The overarching approach to delivery recommended across these policy areas is proportionate universalism, the idea that services should be provided universally, but with a scale and intensity that is proportionate to the level of disadvantage. The prospect of becoming a Marmot borough has been discussed amongst officers at lead member briefings. In Reading, we recognise that health is created outside of the healthcare system. We support these principles and know that there is much good practice in Reading Borough Council and amongst our systems partners in the integrated care system and the local voluntary community sector that already aligns with these principles. The way forward for us here in Reading is to receive the completion of the current Director of Public Health Annual Report, which is expected in March 2024. This statutory document will be the first since 2021. It will be supported by evidence drawn from our joint strategic needs assessment and will provide strategic guidance about our local priorities for protecting and improving health in Reading. This strategic guidance will enable us to take an informed view as to whether we will be recommending to the board the aspiration to become a Marmot borough and the benefits to Reading's residents. You can.
Just to ask whether this topic could be brought back to the board when that report is received.
Thanks, Tom. I think that would be a very sensible idea, so thank you, yes. And Mr. Lake, you have a second question for us.
Thank you. This arose after some confusion about the changes in audiology provision. In the current structure of an integrated core care board with place level structures, it's unclear where commissioning decisions are taken and how they're reported to the public. Will the board review accountability and oversight in our integrated care system so as to clarify where change is needed to bring commissioning decisions clearly to the public view?
Again, thank you for your question, Mr. Lake. The Buckinghamshire, Oxfordshire and Berkshire West Integrated Care Board remains the NHS commissioning body and has a duty to consult with the local authority and the public on any commissioning decisions that would have a substantial impact on services. The Health and Wellbeing Board, along with the ACE Committee, continues to play an important role in co-development and scrutiny of commissioning decisions. Our jointly developed health and wellbeing strategy sets out our local guiding priorities. We will continue to review progress of delivery against this strategy, regardless of whether the development work happens at a place level or as part of the wider Buckinghamshire, Oxfordshire and Berkshire West Integrated Care System.
Thank you. I think I'll leave that at least.
Thank you for your questions, Mr. Lake. Agenda item 4 is petitions, and we don't have any petitions, so we'll move on to agenda item 5, which is Berkshire West Safeguarding Children Partnership, the annual report for 2022-2023, and is being presented by David Goosey. Thank you.
Thank you. So I'm the independent chair for the Safeguarding Children Partnership for Berkshire West, which is made up of Reading, West Berks and Wokingham. We are the only tri-borough Safeguarding Children Partnership in the country at the moment, which is interesting. Presents us, I think, with a range of possibilities for cross-border collaboration, but there are also some difficulties that go alongside it. So this report, I hope, is providing you with a coherent account of the the work of that partnership for 22-23. There's a huge time lag here, isn't there? We're now in 2024, coming up to the end of this year, so I don't know whether this might have been able to be presented to you earlier. There are 3, I think, key themes that I've pulled out from this annual report in my report to this board. One around extrafamilial harm, that is looking to safeguard those children that are at risk of harm from people outside of their family, for things like child exploitation or serious youth violence. We've done some work as well on the threshold arrangements across the 3 local authorities, and this is particularly important for our common partners, Berkshire Healthcare Foundation Trust, TVP, the police, a number of schools, colleagues like the probation service, so that we have a single approach across those 3 local authorities in respect of determining when threshold for state intervention is necessary. And I'm also reporting here on 6 local child safeguarding practice reviews, which were published during that year, not all of which are Reading orientated, some to do with West Berks or with Wokingham. So I hope all of that makes sense, and I'm happy to answer any questions that you might have.
Thank you very much. I'm going to open this up to questions. Councillor Hoskin.
It wasn't so much a question, it was more kind of just some views. So thank you very much for coming along and presenting the report. I think yeah, I mean, we've talked in the past about the tri-borough approach. It certainly provides opportunities and challenges, I think, and those are clear. I think I from my sense from before to the change to afterwards, I think it's the right approach. I think the key thing is like and we know Reading. It merges and it drifts across, into other boroughs while still being the same town. Families move across areas because they don't abide by our borough boundaries, annoyingly. Don't have the same loyalty to the borough that we do. And so I think, this approach is the right one. I think it's showing dividends. I think the priorities outlined here are, well, I suppose I would say they align with us because we've aligned with the priorities that have come out of here, and it's obviously a collaborative process around young people violence. Is one that we're taking particularly seriously, and we have had episodes of violence and stabbings and stuff in the town. We're looking to work collaboratively and effectively across partnerships. So I think that comes across here in the report here as well. And I suppose I think there's some interesting learnings that are sort of brought out in the report, which is really good. And pursuing, someone's sort of calling me, pursuing that, going forward with those. So this is sort of a little bit lapse, but we are pursuing, taking those forward, and that'll be really important in terms of maintaining that priority. Thank you. Sorry, I should have introduced myself as Graham Hoskin, Councillor of Children. Thanks.
Thank you. Do we have any questions from anyone? No, I can't see anyone. Well, thank you very much for attending. It's a really useful report and very interesting to read. So thank you very much. It's quite interesting looking at the can't see what section it is on page 28 in my report about the partnership working, looking at the work with Reading Festival and sort of ongoing and how that kind of welfare of our young people in all areas. So it was a really interesting report. So thank you very much, and thank you. Okay, moving on then. So agenda item 6, which is Health and Wellbeing Strategy Quarterly Implementation Plan, Narrative and Dashboard Report, which Amanda's presenting online.
Yes, thank you, Chair.
Thanks, Amanda.
So I'm Amanda Nyeke. I'm the Public Health and Wellbeing Manager at the Council. I will be going through just a quick update on the progress to date of the 5 priority areas and touching on a couple of points related to the data. From what you'll see, we have developed the Health and Wellbeing Strategy Dashboard now. So the report includes more visual representations of the progress that we're making to date. But just to note as well that there's still some work going on to refine the dashboard. So with regards to updates on the specific priorities, priority 1 and 2, as the report states, are looking, overarching to address health inequalities. And with regards to priority 1, a community wellness outreach project is progressing very well. The Joy platform, which you may have heard of, is what is going to be used to digitize the process and to ensure that the delivery of the program is smooth. The project is a collaboration of work that builds on community-based services that enable referrals, as well as drop-ins for people to receive full NHS health checks. However, the focus isn't solely on the delivery of NHS health checks, but it's a holistic approach. So looking at other wellbeing support. This includes financial advice, mental health awareness, as well as referrals and signposting to other community and voluntary sector services. So it's a really exciting project that's underway. But the main goal of it is around addressing those inequalities to access to services, as well as developing additional capacity for primary care and ensuring people receive timely interventions. So some of the data that I just wanted to highlight under priority 1 was around an increase in prevalence, unfortunately, of hypertension, heart failure, cancer, and diabetes, but this is being seen mostly in the deprived areas. So these are quintiles 1 and 2, and this is in comparison to the total registered population. So this highlights what we know in that areas that experience high levels of deprivation tend to experience higher prevalence of certain health conditions and poorer outcomes. So the goal of this community wellness outreach project is to have some impact in improving this situation and increasing access to services and support. So under priority 2, again, the overarching goal being to address inequalities. There's ongoing work with our voluntary and community sector partners, some of whom are specialists in supporting people with learning disabilities. There's a range of forums that are working to enable engagement and feedback to support the various commissioning priorities across Reading, as well as the wider Berkshire West Place. The Reading Integration Board is funding the Campus Recovery College to deliver mental health outreach projects. One in particular is looking to work in partnership with Prospect Park Hospital and to support people who are at higher risk of poorer outcomes related to mental health. So the focus of this particular project over the next 18 months is supporting those people in high levels of deprivation, but also that partnership working with the hospital. So again, similarly linked to priority area 1, the Joy app is being funded through the Better Care Fund, and this will continue until 2025, which is brilliant. And the project is being led by Reading Voluntary Action. So the app is being used, as mentioned previously, but also as a social prescribing platform to enable GPs to directly refer to community and voluntary sector services. So it's all in the bid to support wellbeing and to make that support that people receive more seamless and more efficient. So to date, there are about 134 organizations that are providing wellbeing activities, and 384 people have been supported through the app, which is really fantastic. So with regards to a quick update around data under priority 2, what we can see is that Reading has a slightly higher diagnosis rate of people aged 65 with dementia, so a higher diagnosis rate in comparison to the national average, which means we're finding people, which is important. So moving on to priority 3. This priority focuses on helping children and families in early years settings. So the progress under this priority area is going well. Brighter Futures for Children the earliest team continue to support all earlier settings to develop a trauma-informed approach to their work with children and families. There are 12 educational psychologists that have been purchased by the team to enable early years practitioners to access support, as well as advice on emotional well-being. There has been an increase in the take-up of the 2-year-old funding from 60% in 2023 in the summer term to 63.2% in the autumn term. And activities to continue to promote this uptake is ongoing. So there's still a lot of work happening across the different areas and the different teams within the partnership. With regards to data, what we can see is that Reading has a higher percentage of children aged 2 to 2.5 years that are receiving the ASQ3. So what this is it covers 5 domains of child development. So we're using this as an indicator to monitor progress as well against this. Moving on to priority 4. So priority 4 and 5 are looking at addressing mental health, with priority 4 focusing on children and young people. So there are various task and finish groups in place to support priority 4, and they're looking at addressing various priorities within themselves. So one is around suicide awareness and prevention, and this is in partnership with the public health team. One of the other task and finish groups is around school attendance and mental health. We have a task and finish group focusing on inequalities in mental health related to global majorities and heritages. We've got a task and finish group focusing on inequalities in mental health in relation to neurodiversity, as well as trauma-informed approaches and therapeutic thinking schools. So there are a range of other 3 more task and finish groups, but the details are in the report. So again, there's a lot of work underway in these individual task and finish groups. And priority 4, the lead for priority 4, is regularly liaising with the lead for priority 5, as there's obviously some crossover happening between these two. With regards to data, we've got some positive outcomes under this priority, with the percentage of children and young people working with the primary mental health team who have moved towards their goals. So this continues to be above target, as we can see in comparison to previous quarters. And finally, moving on to priority 5, which is mental health, promoting good mental health in adults. There is a group, which is the adult mental wellbeing group, that meets throughout the year. And as I mentioned before, working together or working closely with the lead for priority 4 as well. One of the main focus areas of the wellbeing group over the next few months will be to look at the suicide prevention action plan, to review the local action plan in line with the new national strategy and ensure that it's aligned with, as well, with the Pan-Berkshire strategy. So it's all about coordinating scaled up suicide prevention across Berkshire, including bereavement support, real-time surveillance and coroner's audits. So the group is collaborating to identify 2 or 3 priority actions specifically for Reading that can be achieved in the next year within existing capacity. There's also work undergoing to sign up to the Prevention Concordat for better mental health. And the goal of this is to provide an overarching narrative and action plan signed by the local system leaders to coordinate ongoing preventative action in this complex area. In relation to data, under priority 4, we can see that in relation to serious mental illness, although the number of people has decreased over time, the prevalence in the total population, which is rising, has remained at the same level. Reading does have a significantly higher percentage when compared to England of adults in contact with secondary mental health services that live in stable and appropriate accommodation. So that's a positive thing, that there is that stable accommodation being offered and that support. But as mentioned before, there's again a lot of work undergoing, being undertaken to work in partnership and align with our the Prevention Concordat aims, as well as looking at that suicide prevention strategy. Thank you. I welcome any questions with regards to these.
Thank you very much, Amanda. I'm just put my hand up if anybody, has anybody got any? Oh, Melissa.
Thank you, Chair, and thanks, Amanda, for the update. It's really great to see the progress, and the data is really helpful to put the context for our place. So it's really great to see. My reflection was there's lots of activity in the mental health space, really, as a product of how important it is. And I just wanted to sense check whether we felt the strategy and the fact that all partners are signed up to it is really supporting the coordination of all of that activity, and if there is anything else that we could do, because I think there is a risk that there is so much, it needs to be aligned, both from organisational perspectives and from people perspectives, so they know where to access services.
Yeah, absolutely. I think one of the main purposes of the mental wellbeing group is to bring together the various stakeholders that are working to address mental health. So there is a vast representation within that group of people that are working on mental health. So that's a great space for people to share what is going on and to look at opportunities for working together. And as I mentioned before, although that group does have a focus on adults, our lead, who leads on priority 4, which is for children and young people, as well as our lead for priority 5, are often working together and have the opportunity to attend their different groups to feed into that. So there's definitely some good alignment taking place. But I think you are right, there is definitely a lot going on. And I think that's another reason why we're also looking at the Prevention Concordat for better mental health, because that also is looking at how to work together as a local system, looking at the various things that are on offer. Does that answer your question, Melissa?
It does. Thanks. Very reassuring, Amanda.
Thank you, Amanda. Councillor Hoskins?
No, thanks, Chair. Ruth, I should agree. Ruth, is that allowed? I don't know. No, thanks very much. I mean, I could spend all afternoon on this because there's so much in here, and it's it's all fascinating stuff. And as Melissa was saying, I think the data and the representation of the data is really, really good, and I think relatively easy to understand. Maybe I've got the wrong answer, but it does appear to be relatively you can sort of get a real grasp just by looking at the tables and stuff. I'm from a personal point of view, I'm really pleased at how the really strong level of work and amount of initiatives that are really progressing. I think when we were setting this strategy, I was a little bit worried around the language around inequality, which was a bit of a compromise with our colleagues who've now left actually the administration. We had particularly conservative colleagues in Woking, West Berkshire, I'll be frank, were a little bit uneasy with some of the language around inequality. However, it became clear that we pretty much wanted to achieve the same things. It was just kind of the language we were using. And so it's really good to see the sort of the addressing health inequalities runs all the way through this. And you can see this in the graphs and what it's doing. So, I mean, my questions, one of them is maybe a little bit nitpicking, because actually I can see there's good work that's coming out of here. So around the health checks, we're quite interested in terms of sort of previous years, but in some ways it looks quite even. So with the health checks, and you've got like the accessing health checks from the more deprived and the less deprived areas, it could be worse. We could have like a massive inequality there. It's relatively even. Although part of me saying kind of it should be the other way around. It should be, I don't know, I'm looking over there. I'm looking at you, Ruth, aren't I? Part of me feels, though, that we kind of want to be going further in terms of health checks being more prevalent in the most deprived areas and less prevalent in the least deprived areas, and really to address needs. So I suppose that's my question, whether we can sort of continue to focus on that, not achieve parity, but actually to achieve more checks where they're needed. And the other question is perhaps for Lara. I think what I hope is because of the really good work that we've done in the emotional, mental health and well-being area. It's page 68, but on our papers, not this. But it shows some really good data in terms of health and mental health and emotional well-being data for our looked after children and children in care. So I suppose my question is that, are we comfortable that actually reflects reality? Is down to hard work, a blip, or around data collection? Because hopefully it's showing the fruits of really hard work in the area. But that might be more for Lara. Thank you.
Shall I go first?
Yes, thanks.
Okay.
Thanks, Amanda.
So to answer your question, with regards to trying to aim to offer more checks in areas experiencing high levels of deprivation, that is the goal of the Community Wellness Outreach Project, because what we established from local insights and data is that although there might be many people in those areas that want to receive checks, access is not as easy to GP practices. So originally, a lot of the checks were being delivered within practices. So the goal was to increase capacity. The GP practices will continue to deliver health checks, both universal and ideally targeted. But in addition to that, we've got this project that looks to focus on outreach and actually go out to those areas to offer these checks. But as I mentioned before, you know, some people might not be eligible for checks, but they will still receive some form of health support as well as signposting, depending on whatever their needs are. So that is the goal, very much so to reach those people that need it the most, but also maybe wouldn't necessarily easily be able to access the checks.
Thank you, Amanda. And I know Councillor Gittings has a question, but I think Lara wanted to come in first.
I can. I'm not sure if I can answer the question, Councillor Hoskin, but all I can reflect, I'll find out in relation to the dip in, so as it says on the presentation, the mental health of our children in care is measured through something called a strengths and difficulties questionnaire that we undertake with our children in care, or their sometimes their foster carers undertake it with them. I wasn't aware that it had dipped, and it certainly wasn't something that came up in our focused visit in September. What I can see though is that the data here relates.
Sorry, Lara, it might,
yeah,
where dipping is a good thing. It's the percentage with where it's
gone up.
No, it's gone down. So it's a good progression. It's like where, so for instance,
the score has gone down.
Yeah, it's a score. So it's dipped. That's a good thing. So it's the percentage where with mental health needs, emotional health needs, and where emotional health wellbeing is a cause of concern. So it looks like it's good work and it's going in the right direction rather than a cause of concern. I was just kind of interested in that we're comfortable, you know,
yeah,
due to what we're doing and it's, you know, embedded.
No, absolutely. No, I mean, what I was going to say is, no, sorry, you're right. It's going down is a good thing because the score's gone down rather than their mental health has deteriorated. But what I was going to say was it is 21-22 data, and obviously we're a little bit on from that. So I will take it upon myself to check what the current score is and make sure that we are content that that's on at least on a stable trajectory, if not continuing to go down.
That's great. Thank you.
Thank you, Lara. And Councillor Gittings had a question.
Yes, thank you, Chair. So a question and a comment. And apologies for my late arrival, so I did miss some of your presentation, but I've obviously got the notes notes here. Obviously, ACE Committee a couple of days ago, we had a presentation, obviously from the healthcare. From the Berkshire Trust, Health Trust, the Royal Berks Health Trust, on the work, Berkshire Healthcare Trust, on the work they're doing around mental health for children, and the delays in referrals. That was quite shocking, really, and there was a lot of questioning around that. So I mean, this is great that work's going on, but I think there's a reality check, isn't there, in terms of the waits for people to actually be assessed and those type of things. So this is great, and obviously it's important as well that we do the same, obviously, for looked after children, those in care. But it's almost as though the work's almost in sort of running parallel to that, and these awful delays that were highlighted at the ACE Committee. And I just wanted to say something on health checks. I chaired a national leisure panel meeting a couple of months ago now in Loughborough, and what is quite interesting is that Sport England, who probably want to rename themselves Active England now, but Sport England are running lots of pivots, what they call pivots, in communities where they're carrying out health checks in sports centres. And I think in Wigan they had a situation where I think 500 people signed up for a health check one Saturday morning. Incredible numbers. So I'm hopeful that, obviously, with our new arrangements with GLL, and obviously some of the inequalities that we have in Reading that the Councillor Hoskin has highlighted, that we can actually start to get involved in that sort of work as well, because I think it's important actually that we do that, particularly obviously for younger people, but people of all ages that we can do to address that. So that's a general comment, but I'm just wondering what your views are, obviously, on the other situation where we've got such delays for assessments. I mean, I think there was a target of 2 years, which now it's sort of a year and a half, but they were shocking delays, and there was a long discussion at ACE a couple of nights ago about it.
Thank you, Councillor Gittings. And Amanda, did you want to respond to that?
So if I'm being honest, I think the goal really is to find out more about that and have some discussions with the trust, basically, and get some clarity on, where are the connections at the moment? is there alignment with what's actually going on? And if not, how do we take that forward? So I think that would be the first step. But I don't know if John wanted to respond to that as well, or if it's a separate comment. But can I just respond to with regards to your mention about delivering checks through other partners and providers? So there is, I guess I just wanted to add that there are some what we call mini health checks as well that are being delivered within the communities. They are slightly different because there are some sort of mandatory measures that need to be taken as part of NHS health checks. So where people aren't necessarily trained up to deliver the full check, they are offering those mini health checks. But we are exploring opportunities for example, of whether GLL can start delivering some of those mini checks for us. But there is a mix in the community of mini health checks as well as the NHS health checks. So I just wanted to add that comment in there as well.
Thanks.
Thank you, Amanda. And John?
So thanks, Chairman. In response to the councillor's question, I think when it comes to mental health, there are two ends to this. There is the work that we are doing and developing in the council. So much of council activity does impact one way or another, not just on health generally, but on mental health. And, we have an ambition to grow and develop that work. But the increase in the public health grant in the last 12 months is only between 1% and 2%. So it's less than inflation, and we don't have adequate resource, and we know how stretched the council itself is. When it comes to the other end, which is child and adolescent mental health services, they are a national disgrace. And the successive administrations nationally have said they were going to give parity to mental health with physical health, but it's never happened. So I think the elected members may feel that they have an opportunity here to influence a potential incoming administration to take this more seriously and deliver on it, because we can't do anything about that from the council. What we really need is the National Health Service to give equal attention to mental health, and particularly to that of our young people. So I think we have to advocate for that from here, because there's a limit to what we can do about it. Thank you.
Thank you, John. I have somebody else that wanted to speak. Tahina?
It's Tamina. Hi, thank
Tamina,
you very much. Sorry, it's a bit of an echo. So I'm the Chief Operating Officer at Berkshire Healthcare Trust. I wasn't at the session that you were describing, but I obviously, one of my divisional directors with her team we're talking about some of the challenges and CAMs. I suppose one of the things that's really important to do is differentiate between the different types of services that we deliver. So the longer waits, which I completely agree are ones that we're not happy with, relate to autism assessments and to ADHD assessments and treatment where that's indicated. I think it's really important that we work closely with our local authority colleagues around this, because an assessment and a diagnosis is only the very first stage of the process. What we really want to do is be working with schools, families and communities around how people who are neurodivergent are accepted and reasonable adjustments are made. So that's kind of one part of it. The other part of what we do around children's mental health is there's something called the Thrive model, which has got 4 levels to it. So getting advice is the first. Getting help where it's indicated that people need more active intervention. There's getting more help where they need a higher level of clinical expertise. And then there's getting risk support, where we have young people who go at a high risk of of self-harm or continued mental health presentations. And then alongside that, we have the work we do around crisis support, which is something that we respond to very quickly. So I think it's worth just recognising that response times for each of those different offers are really quite different. The very long waits do relate to neurodiversity, and not that they're acceptable, but there's a whole range of services we provide around the whole sort of breadth of mental health need in our young people, where the wait times and the offer is really quite different.
Thank you. Do we have anybody else that wanted to, any questions or comments for Amanda? No, thank you very much for for that report, Amanda. It's really good to see the progress on the dashboard. I just had a really quick question. A lot of my sort of comments have been covered by colleagues. It was just about the going through the report, the amber status updates, and you mentioned some of this. So the progress, I can't see it. As priority 5, the befriending scheme in relation to mental health. Was that to do with the Compass Recovery College, the befriending scheme?
No, that's not specific to Compass. It's more working with our voluntary community sector partners around that. So there is still some work to be done there, which is why that particular action is amber. Yeah.
Oh, so it'd be useful to know more about that, possibly at the next meeting, see how that's progressing.
Okay, absolutely. I'll get an update from the lead on that.
Okay, brilliant. Thank you very much, then, Amanda. So I can't see anybody else with a hand raised. So thank you very much.
Thank you.
Okay. Moving on then to agenda item 7, and it's the Better Care Fund integration update, and Bev Nicholson is here presenting for us.
Thank you, Councillor McEwen. Okay, so I've shared the presentation on the screen. This is just a summary of the full report that's in the pack. So I'll try and put that on screen share, just so that you can see it clearly. There we go. Yeah. Okay, so the first slide just covers the Better Care Fund quarterly return that we are now required to submit. We're back to normal processes now. The Q1 return was signed off under delegated authority in consultation with Councillor McEwen and Melissa Wise, and was submitted by the due date. All required reporting criteria was met for the quarter. And we also had to submit a refreshed hospital discharge and capacity demand plan, which we did. There was an acknowledgement actually from the Better Care Fund team that everybody is still really struggling with effective demand and capacity planning due to issues around data quality. So it's worth bearing that in mind. It's something we're all working on as a partnership together. We did also update the plan, the discharge capacity and demand plan, to try and account for some increased capacity for complex care beds, because they're really the most challenging ones and cause the longest delays and wait times. The Section 75 Framework Agreement, which we had agreed would be submitted, is now ready for signing and sealing. So we're hoping that that will be finalised by the end of January. The Framework Agreement sets out arrangements for the management of the Better Care Fund across the Integrated Care Board and with Reading Borough Council, and sets out all of the schemes that were funded through the Better Care Fund, and also incorporates the funding we've got now for the Community Wellness Outreach Project, which is coming from the Inequalities and Prevention Fund. So just a bit of data here on performance. So the number of avoidable admissions and unplanned hospitalisations for chronic ambulatory care conditions is within target, and we are on target towards the end of the year. And the same for a number of emergency hospital admissions due to falls and frailty. In fact, we're significantly below the maximum target for that one. That was a new target introduced this year, so I'm sure we'll adjust our targets for the next period. The areas that we've got some concern in are a proportion of people that are discharged home, and directly home from a stay in hospital. This has dropped slightly. It's not a huge difference from our target, 92.2% target, 91.7% performance. But it's an indicator of the complexity that we're seeing of people being discharged from hospital. So we did some analysis on the data, and we've noticed there were some significant spikes in the number of admissions into nursing and residential care homes in June and July in particular. And overall today, there's 50% overall increase compared to the average admissions for the same period in the previous 3 years. So there really is a spike there. And of those people admitted, approximately 25% of them are now requiring complex care placements compared to 8% in the previous 6 months of the year. So we can see that increasing complexity and need, therefore increasing costs and pressures on the local authority. But we achieved the target for 91 days, which is, you know, as many people who have attended these meetings on a regular basis, that's normally one we miss, but we've hit it for the last 2 quarters, so that's really positive. Just a quick overview of the financial performance. So we've currently got a forecast variance of 8,500. There are some projects which are funded, but the funding is committed. And although they haven't started yet, because we've had a shift in the funding requests that came back to the Integration Board to extend that funding over a longer period, we've committed that funding to spread across that period. So the funding is still allocated. And the council funding contributes towards the overall costs of adult social care services. So that's the top line, to support hospital discharge, reablement, physical and mental health care packages, carers assessments and advocacy. The Buckinghamshire, Oxfordshire and Berkshire West Integrated Care Board budget line covers project management office costs, risk share and contingency, as well as the cross-BOB ICB hosted schemes, which cover the out-of-hospital services to support hospital discharge, intermediate care services in the community. So all really contributing to those 2 high-level BCF objectives of keeping people well, safe at home, and making sure they get the right care in the right place at the right time. And then just a quick overview of the discharge fund. The fortnightly returns have now been replaced with monthly returns, which I'm quite relieved about. And we've continued to submit those in line with the reporting schedules. The last return that was submitted shows the expenditure up to the end of November. Since the report was published, we've actually submitted another return, which I'll give an update on at the next board meeting. But to date, we've spent 73% of the 1.2 million budget that we have for the discharge fund. I referenced the high cost of complex care beds earlier and the increasing number, which has led to an overspend on that line of just around 250,000 at the moment, and creeping up. So it indicates that increasing complexity and the pressures on adult social care. We've been advised that the discharge funding will be increased in 24-25, but quite a significant increase in that. So we've adjusted the planned spend to increase the allocation of complex care pathway 3 discharges so that we can accommodate that in the next financial year. So that's my report. Are there any questions?
Thank you, Bev. Welcome to the report and good to see the continuation of the successful work. And I'm going to open this up to questions, and I can see Councillor Gittings wanted to speak.
Thank you, Chair. I mean, actually, I was doing it for this other one. Which is probably a good thing for the viewers. Thousands of viewers are watching. If you sit over there, you're not in shot and just hear your voice. So at least this mic is working. Yeah, so I was doing a tour of our adult social care settings, number of places, and this was directly raised, a number of people presenting with complex needs. So and obviously we've slightly missed a target, and I don't think this is surprising, and I think this is the comment. I think it's not unsurprising that this is a trend that's going to continue. I don't think there's any sign that this will be turned around any time soon, and a lot of it is to do with some of the issues that we're talking about, health inequality, and also probably off the back of COVID and other situations. So my question was going to be, what are we going to do to meet that future demand? So I'm partly reassured by the fact you said that we had some extra budget next year to do that, but I suppose my question would be, is that going to be enough budget based on the trends that we're seeing? And this is because it's a clear pressure on the health service, but also on adult social care quite directly, and it is a bit of a concern.
Well, the budget that we're proposing for next year is taking into account all of the costs to date for this year, and that forecast trend, looking at historically, the numbers have always been higher. The admission numbers have always been higher in the first part of the year, and they drop in the latter part of the year, and that hasn't been the trend this time. So we've accounted for that in the forecast and added a little bit of contingency on top of that. So you never can know whether it's going to completely cover those costs, but we feel that we're in a better position for next year, and that increased budget income for us will make a huge difference in terms of trying to address that need.
Okay, thank you.
Thank you.
Thank you, Bev. And John?
I think members and officers may be interested to listen to a programme that was on this morning on Radio 4 called Why is Local Government in Such Trouble? And it was looking at the financial side and so on. And part of that was the issue about increasing demand for SEND services. It was a good analysis, actually. And, you know, part of that is obviously to do with increased identification of youngsters. But also there are real issues about the quality of maternity care, which may have an impact on the numbers of youngsters who have, you know, damage at birth. And it's something I'm wanting us to look at locally, but there's a national issue, the national concerns. You may be aware that the number of maternal deaths has gone up during pregnancy and delivery and after. And for every mother who dies in relation to childbirth, there will be a number of babies who are actually suffering as a result of that. So we need to look upstream to see what's going on in the health service. We need to be asking questions about whether the health service should be paying for some of the care that's required as a result of failures of the NHS. But we really need to put the spotlight on the prevention agenda there, as well as what we can do as a council. So I think it's important to have that rounded perception. But I'd recommend on that listen again function on the thing, it was 11 o'clock this morning when I was in the car, David Aronovich's programme. Thanks.
Thank you, John. I have to say, I listened to a little bit of that and I was thinking I'd listen to it again properly. So thank you for that. Thank you for your comments there. Do we have any other questions for Bev? No, well, thank you very much for the report, Bev. Thank you.
Thank you.
Okay. So moving on now to agenda item 8, which is the Berkshire Suicide Prevention Strategy 2021 to 2026, a progress report. And Martin White is presenting.
Thank you, Chair. My name is Martin White. I'm consultant in public health at Reading Borough Council. This report provides the board with an update on the Berkshire Suicide Prevention Strategy, that's 2021 to 2026. And the board have received a copy of that strategy, the refreshed implementation action plan, and a copy of the Reading action plan with the audit tool, which is used to map current activity. A little bit about the context for this. It's important to remember that suicide and suicide prevention is a complex issue, and prevention should be integrated into other local strategies and programmes, including the commissioning of other public health and wellbeing services across the life course. Suicide prevention remains a high priority for public health teams across Berkshire, but the complexity of the public health system, with its 6 different local authorities serving diverse populations, presents some challenges to the development of a strategic approach to suicide prevention. Due to these complexities, the 2021-26 strategy was not universally adopted by all 6 local authorities, and consequently the coordination, production and oversight of the strategy refresh has been delayed. Recently, in September this year, 2023, beg your pardon, the government has published a new national 5-year cross-sector suicide prevention strategy with an action plan, and the current strategy and the implementation action plan are aiming to be aligned with this new national strategy. So in terms of implementing it locally, the following actions are listed in the report which have taken place, which will support its implementation. We've now got John Ashton as the interim lead director for public health for suicide prevention for Berkshire. We also have Mike Bridges, who's an interim public health consultant who's leading on suicide prevention for us. We've reviewed the priority actions and made recommendations. We've developed the audit tool for local authorities to use to support the local implementation and identification of local priorities. We've got local area action plans, which are implementing the strategies. We have a regular meeting where the suicide prevention leads meet to support delivery and share good practice. We've got a real-time surveillance system workshop in Bracknell on the 30th, which Mike and I are presenting at. We also have the Berkshire Suicide Prevention Group, which meets quarterly with the objective of driving the whole agenda forward. Recognising the complex mix of factors which contributes to suicidal ideation and contemplation of suicides, no single agency can prevent suicide in isolation. So, collaboration, intersectoral collaboration will be important, and the different approaches will be needed to implement the strategy at a local level. The audit tool that I mentioned earlier on serves as a comprehensive mechanism for evaluating the strengths and identifying areas for improvement in each of the local action plans, and to help establish connections with pre-existing local strategies. The Reading Suicide Prevention Action Plan, there's an action planning group which has met on a regularly quarterly basis since March 2023. That's led by me in partnership with Deb Hunter, the Principal Child and Educational Psychologist from Brighter Futures for Children. The group has actively engaged and has established a network of stakeholders. We're almost through reviewing the local plan, building upon the previous version, which was from 2019, pre-pandemic. And the recent publication of that national strategy has provided us with an opportunity to align local action with broader national strategic intentions. And it's also facilitated the coordination at scale with partners across Berkshire, particularly in the areas of real-time surveillance, bereavement support and coroner's audits. They're three important aspects of suicide prevention which can't be done just at a local council level effectively in Berkshire. The overarching objective of the review is to identify 3 priority actions for Reading that align with the priorities in the local suicide prevention profile and the national strategy. And these actions will be targeted to be achievable within the next year within the existing capacity. Currently, we're focused on the early part of the life course, particularly linked to the experience of self-harm, that's priority area 3, middle-aged men, priority area 5, and measures aimed at restricting access to means such as potentially high-frequency locations. We also have ongoing work that delivers suicide prevention training for teams in public-facing council services, which appears in priority area 5, and currently scoping the development of a more robust pathway around the Adult Social Care Advice and Wellbeing Hub. I'm ready for any questions, Chair.
Thank you very much for that report, Martin. Do we have any questions or comments? Councillor Gittings?
Unless, yes, that's one off. I suppose it was on your earlier remark about the lack of coordination amongst the unitaries in Berkshire. I mean, there are 6 of us, which obviously does lead to some difficulties in here. So I just wondered, is that been sorted, or what was the barrier in the first place?
Well, I think the barrier was that when it's like herding cats, I suppose, Councillor Gittings, you've got 6 different opinions. 6 different officers, there's churn within the system, we had a pandemic, and then there's the diversity, you know, the needs of suicide prevention in places like Slough and Reading vary from those in, say, West Berkshire and Bracknell and Maidenhead. So it's coming to terms with all of that, really, and picking up the threads of work that's been done previously. There was some work started in early 23 that was paused, and we've reverted back to the original strategy. To answer your question, yes, and it's because we've now got a DPH, John Ashton, that's leading on this, supported by Mike Bridges, and that's helped to provide a bit of stability so we can bring the stakeholders and partners together. There's the added complexity that some of it, for instance, the bereavement support is commissioned at Thames Valley level, which, you know, it's the old story of the geographic boundaries not aligning. You know, they're not coterminous, so we have to reach out across the usual partnerships to draw people in to have those conversations. For instance, we've got to get organised for the recommissioning of that service across not just the 6 Berkshire authorities, but Thames Valley.
Okay, thanks. So it appears that you are being, hopefully, John, be successful herding the cats, because this is, you know, it's vitally important, because we've seen obviously national reports of suicides, particularly amongst males, going up quite considerably, and it is a real concern.
It is of real concern. The long-term trend is that 3 out of every 4 suicides is likely to be a middle-aged man who's lost in life, lost a relationship, lost his income, lost his sense of purpose and meaning. And we also know that there's a strong association between economic adversity and economic downturns and a rise in the cases of suicides. What I would say is to sound a note of caution about talking it up, because if we talk it up, we put vulnerable people at risk. Stay tuned to what OHID Fingertips is telling us about the suicide rates. In fact, in Reading, as we know, we've got a rate of 9.2 for all people. This is lower than the English rate, and for males it's 13.6, which is lower than English at 15.8. But sadly, the women in the borough are facing higher rates than national. They're 5.5 per 100,000. So yes, it is of huge concern. This has been a public health policy priority for several years now, but we don't have the funding that's been allocated to it in previous years. So we are facing some challenges. John.
So, Chair, should I come in now?
Oh, sorry.
No, don't. Yes,
sorry,
please,
Chair.
John. No, don't you worry. Thank you, John.
So John Ashton, Interim Director of Public Health. Just a few comments, really. Martin's covered it well. Prevention of suicide actually begins right at the beginning of life. I mean, it's about ensuring that children have a good start in life. So it starts with the first 1,000 days and all the things that we're putting the focus on in terms of school readiness, preventing school exclusions, and aiming to have young people ready for the world of work or higher education at 18. That's the basis of resilience. The numbers are not large, but in aggregate they add up to some thousands a year nationally. But at any particular borough level, you're only talking about some few dozens of suicides. And actually getting to grips with the prevention involves a forensic understanding of where they are happening in terms of age, method, location, and where the opportunities are to intervene when people are in a suicidal frame of mind. So for example, where I was working in Cumbria, we had hotspots where people would go to the Lake District to take their lives because they had fond memories of there from earlier in their life. So we had hotspots that we needed to take environmental measures, which might prevent a handful of suicides a year in Cumbria. And also we had a bridge over the motorway near to a psychiatric hospital, and it wasn't protected to stop people throwing themselves off the bridge. So we had to take environmental measures. And I think, you know, our understanding requires us to really drill down and see where you can save 2 or 3 lives here, 2 or 3 lives there, and so on. And that brings me on to the work. Martin says he's involved with a workshop we're organising on timeliness of data, because the relationship with the coroner's office is really important. And we have the one coroner office for Berkshire, and getting timely notification of events, particularly now that the coroners are required to report on avoidable factors in deaths to enable to learn the lessons from those. So we're wanting to tighten up that side of things with the coroner's office so that we can be in a better position to take preventive action. I think those are all the comments I would make. Thank you.
Thank you, John, and thank you, Martin. Yeah, I welcome this report. And firstly, I want to say, you know, as a board, you know, what can we do to support the ongoing work? But I just have a quick question or comment. Obviously, reading through the priorities, which are all incredibly important. I can't see what page it is, but the mention of the links with domestic abuse, and the report highlights the potential link between domestic violence victim and suicide. And I just wondered if you can talk a little bit about ongoing work. It mentions sort of improving data collection regarding domestic violence and providing information to domestic violence abuse services, and how is that progressing? Because you mentioned the increase in female suicide rates.
Yeah, it's very important, and it fits into that wider picture of a public health approach to violence prevention. I can't give any detail about that, but I can report back to the board separately. We haven't had a meeting since October, so the partners in the action planning group would be better placed to give an update on the detail of that. But the main thing to note is that we've got this as a priority within the plan, which it didn't appear before. And as I said earlier on, the data in fingertips is showing that we have got a matter of urgency in Reading here, with a higher rate than compared with England. So yeah, I can provide a more detailed report to you about that, Chair, if you would like.
Yeah, I think that would be useful. Thank you, Martin. And John?
So yeah, just to underline what Martin's just said, you know, I mean, nationally, there's a woman murdered by her intimate partner every couple of days in this country. 30% of women have been abused at some point. And when it comes to women taking their own lives, it looks as though it could be as many as 50% of women who take their own lives have been abused. So this is a really important area. And thank you, Chair, for making us come back to it.
Thank you.
Thank you. Okay, thank you. I can't see anybody else indicating, so thank you very much, Martin, for presenting. And we're moving on to agenda item 9, which is Reading's Armed Forces Covenant and Action Plan. And it's been presented by, Alex. Alex.
That's correct.
Sorry, Alex, I couldn't see your name there. Thank you.
Thank you. So I'll just introduce this item briefly. So my name is Alex Wild, Policy and Performance Manager at Reading Borough Council. I'm here today on behalf of Jill Marston, who's unfortunately unwell. So I will do my best to answer any questions you may have about this item, but apologies in advance if I'm not able to give you an answer straight away. I will endeavour to go away and get a response back to you as soon as possible if there are any questions. So just to introduce this item, this report presents an annual update on progress against the actions outlined in the Armed Forces Covenant Action Plan, in particular the health-related actions. That action plan is set out at Appendix A, A couple of points to note. To note the new legislation relating to the Armed Forces Covenant and duty to pay due regard to the Armed Forces community, the development of the Berkshire Civil Military Partnership, and the progress against the actions set out in the action plan. So I will hand back over to you, Chair, and any questions.
Thank you very much, Alex, for the report. Do we have any questions from anybody? I can't see anybody online. No, thank you for the report, and you know, it's really useful to get the update, especially around the health and well-being and the ongoing work that is going on. Sorry, Andy has got a question.
Thank you, Chair. Andy Chersky, GP. There's been quite a lot of promotion from the British Medical Association and the RCGP to get practices to on board as sort of good practice for registering veterans. I don't know if that's come up in any of the work you've been doing. Certainly my practice and my neighbouring practice have sort of signed up to try and become registered as an RCGP good practice for looking after veterans. I don't know if you've got data on how well other practices in Reading and Berkshire are doing to support our veterans. Thank you.
Alex, did you want to come back?
I can do.
Yeah.
Yeah, I will again. Jill Marston is the expert on this, but I would just refer to point 3 on the action plan, which gives the update that 395 veterans are currently coded in Reading GP practices. As part of an action to devise a protocol for GPs to register veteran status. I don't know if that answers the question, but John may wish to add to that.
No, I don't have any data. I was going to ask you whether we're joined up with the Safa Sisters, the force's own social services and their aftercare for vets.
I'm not all. This is one of the challenges that GPs have, because they sort of ask new registrations as to whether they are veterans, or we go back to our old patients and ask, were you a veteran? Because some of them haven't told us. I think if there's some being discharged from the armed forces, I don't know what the process is for sharing information that they are veterans. We used to have a lack of being able to get hold of their medical records whilst they're in the military for various possible secret reasons, but things have changed now that we can actually request their medical records whilst they've been in the military. So I think the processes might be changing. I think there needs, as you say, John, I think there might be some more joined up working between the armed forces when their personnel are discharged into the community, and them trying to link them into community services like their GP practices.
I think things have moved on. I'm sorry, I don't know. I seem to have the feedback here. I don't know at home. I think things have moved on. I mean, you know, the starkest example I have is not from here, but from at the end of the Vietnam War. I had a friend in the States who was telling me that one week he was in the middle of the Tet Offensive in the jungle in Vietnam, and the next week he was back home on Main Street in America. You know, no decompression at all, nothing, just flown home and dropped down. I think the British Army has made progress, you know, over the years, but we need to assure ourselves that the dots are all joined up, really.
Thank you, John. Do we have any other questions or comments from colleagues? No. Okay. Well, thank you very much for presenting today, Alex. Thank you for the report.
Thank you.
Yeah. Right. So moving on, agenda item 10, which is the Bob ICB update briefing.
Thank you, Chair. I'm Sarah Webster, the ICB Director for Berkshire West, which covers Reading, West Berkshire and Wokingham. This is a kind of a standing agenda item update. I'm not going to read through it line by line. A couple of things that I would just pull out though, which ties into a lot of the conversation we've been having today quite helpfully, and that's through no coincidence because we've all been working on this together, is the update report touches on some of the shared system goals, the areas that we really want to kind of hone in and focus on almost relentlessly over the next 12 months as an ICB and within the wider systems. And it really is a focus on prevention. How can we be more proactive and preventative in the work we're doing, with pleasingly a particular focus we want to be having around children and young people's mental health, prevention of cardiovascular disease and related events, which we know are unfortunately the main cause of early death amongst our residents. And when we look at it through an inequalities lens, we know that unfortunately where you live and the job you do and your personal background makes it more or less likely that will happen to you, which is unacceptable. So the work we're doing around outreach into those communities in particular is so important, and it's good to see that's recognised in some of the shared system goals that we're proposing. And then also with a focus on better integration of our teams to break down some of the barriers between organisations and wrap services around communities in a way that sometimes we struggle to do at the moment. So that's just a highlight of a couple of the shared system goals. There was a link to all of them in the document as well. Very happy to take questions on those. And then the other one just to highlight is around the primary care strategy that's noted in the document. And again, because of the timing of this update, it's moved on slightly, and we've now published a draft strategy that's out there in the public. And I will, with permission from the chair, circulate a copy of that with the after the meeting, which includes a link to the public engagement site, where we'd really encourage everyone to have a look, share your views and comments, and we really want to listen to feedback on this. Again, it's the key areas of the strategy around primary care. And just to clarify, when I talk about primary care, I mean general practice, community pharmacy, dentistry services and optometry. So really core strands of our primary care services. The strategy has it acknowledges some of the challenges that we're facing at the moment as a system, and that the gentleman to my right feels firsthand a lot of the time, and that we all as residents feel when we're trying to access these services. And we can be quite open about the fact that we've heard this, we've listened to the public, and we understand that it's not working in the way that we'd want it to be 100% of the time. And to try and address that, the strategy highlights kind of three key areas that we want to focus on initially. And the first one is around how might we take a different approach to non-complex same day urgent need for those people who are lower risk or have lower risk presentations on that need. That currently we're seeing a lot of residents accessing multiple services because of the way we've set up our services, that creates a level of demand in the system that is hindering us, I think, of being able to really take that proactive and preventative approach that we'd like to do, because we're really struggling with that same day need. So can we do something slightly differently by all working together to address that? And that's outlined in the strategy. What that will then enable is us to have some, going back to the idea of integrated teams in communities, if we're able to free up time of colleagues in general practice and wider primary care to really work with wider partners to take a more proactive, preventative approach to support our residents to stay well, to better support residents who may have multiple conditions, to manage those to stay well and healthy for as long as possible, in a way that we're currently not able to do despite a desperate will to do so. And then the third area is, again, really pulling out a focus on cardiovascular disease prevention, which the work we're already doing here in Berkshire West, I think we're on the front foot with that. And we've heard a lot about the community wellness outreach model today that I'm really excited about getting up and running. And it's already kind of launched here in Reading as well. So we've got some of the building blocks in place here in Berkshire West that align to the strategy. It's just clarifying how as a system we might come together and really relentlessly focus on this and drive this forwards. So I would, we'll share that information. I would encourage everyone to have a look at that, provide your feedback and comments. We're doing a lot of engagement on this as well. We want to hear people's views and feedback. So we're meeting with the patient representative groups. We're going out into our communities to talk to people about it. We're coming to sessions such as this. Hopefully we'll be on the agenda for ACE, if not already. We want this to be a big open conversation. I'll pause there and take any questions.
Thank you very much for the report and the update, Sarah. Councillor Hoskin.
Yeah, thank you, Chair, and thank you for the report. It's always interesting and good to see. I mean, what's going on, and reflecting a question earlier from Tom over there. It is the case, and I think it is more difficult with the largest area that is now covered in the ICB and the sort of diminished local. I know you're doing your best there. It does feel more distant. Things are going on further away, and I think that's a shame. And I suppose it's it's how we address that is one of the big questions which was raised earlier. I'm really interested in the primary care area. Obviously, it's an area of the NHS is under massive strain, isn't it? And put it mildly, but primary care is one that is a particular issue, and people do complain incessantly about, and I understand why. So really, I'll look forward to having a look at that. I think there's some of the things I'm going to say really are kind of in the national context. So, but I'm interested in how we can address them locally. So. Everyone's kind of agreed that primary care is critical, particularly general practice. Actual primary care is critical to the function of the NHS, and yet we're continually, the country is continually providing a smaller and smaller proportion of the NHS budget to primary care, and that's continuing. I do think part of that is due to the new structures, with the local voice being lost. The acute providers, I think, have got a stronger voice in the NHS now more than ever. But I'm interested in what we might be doing in Bob to address that. That's sucking all the the resources into the acute sector. When it says here, well, it's clearly an issue to address within the strategy. So I'm interested in that. I'm interested in the continuity of care. I think it'd be really, because the Fuller report is really interesting evidence around continuity of care, really difficult to address. I think, and probably Andy might know, or other people know better than me, that some of that information, some of that evidence was actually around individual person continuity of care. So we actually seeing the same, like in Norway, I think they have some really good work in terms of the same doctor seeing you on a regular basis. So I'm interested in how you can, talking about continuity of care around teams, but also continuity of care around an individual that might be, concerned for your health, I think is important, a real hard challenge. And the other thing is, and I know it's in here, and I know you're trying to do things, I think part of the problem is how the idea of equity within the NHS, the data around the gaps in good health between the poor and the wealthiest areas in the Bob area, 10 to 15 years is shocking, and it does feel to me that within the NHS, and I guess it's about lack of resources so much being sucked up into acute care, that the ability to really address that doesn't match the scale of the challenge in terms of that inequality of health. So I'm interested in how far that is looking to be addressed, because I'll be honest, the worry is that you've got an area that you cover in Bob, which is largely some of the most prosperous and wealthy and healthiest areas in the country, and then you've got smaller areas, including parts of Reading and parts of Wickham and parts of Aylesbury and parts of Oxford that are really not, and have real strong areas of deprivation and particular ill health. And the concern is that they're kind of not addressed in the way that they should be. The opportunity is they could be addressed even further, because there are particular pockets. So I'm interested in how far that's going to be addressed. Thank you.
Thank you very much. 3 really easy questions for me to answer there. So the first one, in terms of the NHS budget to primary care, I think that's something that through the strategy and the work we're doing around trying to move to a more preventative model, we absolutely embrace the challenge of how do we make sure that we are investing our resources in the right areas to make that happen. It's easy to say that. How we then get to that is something we need to work through, and the strategy is the starting point to kind of lay those rocks in the river to say this is what we're going to do to kind of to try and get there. but I can't sit here today and give you the exact answer of how and what's and how we're going to do that. I think you'll, as all public service are at the moment, incredibly financially constrained. And so being able to transform whilst maintaining safe services in the meantime without disrupting everything is the challenge that we're all continuing to face. But I think by being very public about the strategy around this is the aim. We want to be a more preventative health service is the starting point of hopefully some systemic change. In terms of continuity of care, again, I think the strategy seeks to enable us to do this in a way we aren't at the moment, by being able to release a level of that capacity to focus on local support to our communities through either a kind of the same team or the same individual where that's possible, would be one of the aims of the strategy. So because it is acknowledged that where someone is more complex, has more long-term conditions, actually seeing the same person if we can't manage it for the whole population, managing it for that cohort of people who are identified at higher risk would be the best place to start. And I don't know if Andy wanted to add to that in a moment. Your third point around life expectancy variation, you're absolutely right. If you look at the data, there is a variation of 10 to 15 years, depending on where you live, which is reflected across BOB, but it's also reflected in our individual boroughs as well. And the work we're doing in terms of, for example, the community wellness outreach work is starting to try and address that. So we're looking at those areas where life expectancy is, frankly, that there's this unacceptable gap, and taking services out into those communities, such as the health checks and preventative work. It will help us then target more input from community services, voluntary sector. It's almost a fact-finding mission as well to understand what else can we do to help with that, in the hope that that will start to shift the dial on that life expectancy variation. Andy, did you want to come in at all on the continuity of care point?
Yes, thank you. I think there's a balance between in our workload of doing on the day simple things and then dealing with our older, frailer, more complex, multi-condition patients. You'll see some GPs really want to work at the top of their license and use their skills, medical skills of dealing with undifferentiated disease, the complexity. Often in the hospital, specialists will deal with their bit, but they don't deal with the other bits, whilst the GPs have to take all the aspects and all the different conditions and try and manage them between all of them. That sometimes takes time, and I think it's also getting to know the patient that's living with complex disease needs time, and I think that's where GPs get frustrated, because sometimes processes mean they are treated the same as the on-the-day simple things, whereas actually they need extra time. It's partly organisation, partly processes within practices, but it also means time and resources to allow for that. I think a lot of the work that Sarah's doing on the system on the same day access hopefully will free time up for GPs to be able to do that. But we need to do it in a structured way for the whole of our system and for all of our residents. So again, we don't have these pockets of where things are done differently, and then in some places it's done one way, some places it's done differently. As a system, I think this is the big ticket item for us going forward for the next 3 to 5 years. If we can really nail how do we deal with same day issues in a universal offer way, that will then free up in the background what we can do in general practice for prevention and looking after our most frail people.
So I just thought one other point around in terms of life expectancy variation, I might be, well, John might want to add on to this as well. But as mentioned in one of the answers to the questions at the start of the meeting, we know that health outcomes, there are so many wider building blocks of health that aren't just the health services. And so I value the relationship we have with public health and colleagues here at the council, because we know that there are things in terms of the wider services and provision that you provide that can also have a huge impact on life expectancy of our residents. So I think it's that the focus on partnership working and kind of breaking down the historic boundaries between organisations is really important if we're truly going to tackle this going forwards.
Thank you, Sarah and Andy. John has got a question. John wanted to come in.
If I may, I've just got a few points to make. I've got feedback again. Is that your end or mine? I think it's probably yours. So we're very fortunate to have Sarah in the role that she is, because she's really engaging very well with us in public health, but across the Berkshire West patch. I mean, Bob itself, you know, is a massively insane territory, and someone has to make it manageable to be able to deal with it. So we're very fortunate to have Sarah. At the risk of being pedantic, I'd like us just to be clear about the words we use to talk about primary care, because Sarah talked about primary care as including the community health services like pharmacy and the other standard ones. What's happened over the last post-war period is we've gone from what those among us who are a bit older will remember as general practice, which was sometimes even just a single-handed person in a lock-up place in a house. We've gone from that to primary medical care, where you have teams of medical and clinical people working together. But we're struggling to make the next step, which is primary health care, which is a public health concept, and which in her comments Sarah touched on, because primary health care reaches out to the community as well, and to the other organizations and institutions in a locality that have an important contribution to make. So it's integration at the very local level, really. And you have to remind ourselves constantly that 90% of healthcare is by families and friends. It's not by health professionals. But the conversation usually starts with a hospital discussion. And there are discussions going on at the moment about rebuilding a hospital for Berkshire. And it may be that some kind of secondary or tertiary facility may be appropriate, but we shouldn't start from that end. We should start from the end of how do we optimize health and support self-care in the community, and work through from that end, because otherwise there's just no way in which the NHS will survive, or the contributions that local governments make will survive. So the concept of proportionate universalism has already been mentioned by Martin, is that we have to match what we do in a proportionate way to people's needs. But there are some paradoxes here. Sorry about the dogs. There must be a delivery going on here. There's some paradoxes here, because if you live in a well-off area and you're fortunate in your circumstances and you live into your 90s, then you may well require extensive social care later on in life. And ironically, those local authorities that have kept their council taxes low for political reasons now find themselves embarrassed by not having the funds to support social care. But equally, there are also the problems of social isolation that come from living a long time. And for, again, those better off people who might finish up, particularly thinking here of women, who tend to live for several years longer than their partner, living on their own in a family house, maybe without transport any longer because they no longer are able to use a family car or whatever. And so, there's a lot of other issues we have to address here about how we get the right kind of housing type in the right places to support independent living and avoid hospital admissions in the first place. Just a final point is that what we really need is super generalists in clinical practice. In a sense, we need GPs to be skilled up to a higher level than perhaps has been the case in the past, to be more like general physicians in some ways with their multidisciplinary teams. And in hospitals, we need more generalists because if you are fortunate enough to live into your 80s and 90s, you're likely to finish up with half a dozen different consultants to see. when actually what you really need is one generalist who knows what they're dealing with. And it's much harder to be a good generalist than a good specialist who's only seeing the same sort of things over and over again. So it's very complicated, this. I think what's important is that we get everybody on the same page over the next 12 months, perhaps, because I don't think everybody is on the same page at the moment. And there's a danger that we might have a capital investment decision about hospital building when any capital that is available might be better spent on strengthening community and primary care facilities. So I think this conversation is really important, particularly at this stage.
Thank you, John. I think Sarah wanted to come back, and then we've got Councillor Gittings.
Thank you. And thank you, John, for your kind words, although I'm now suspicious of what you're buttering me up for. So I'll wait for the request to come into my inbox. Just on the Royal Berks rebuild programme, and Andy Statham, who's on the call, might want to come in on this as well. I think it's fair that the Royal Berks have done quite a lot of focus in trying to make sure they're part of that programme and getting the acknowledgement that the estate that they're operating in at the moment isn't fit for the long-term future. But they absolutely are committed to opening up that conversation to say, well, what should the future kind of clinical blueprint be for our services that's ideal and not just replicating like for like, and then what does that mean in terms of what we need to build to meet that. Under Andy's leadership at the hospital, I'm working closely with him on that as well, to start having those conversations in more detail. And John, you and your team will absolutely be invited to be part of that, because I think that's really vital. And then we'll continue to engage with members around the room as that develops further.
Thank you, Sarah. Thank you to John, and over to Councillor Gittings.
No, I was going to, I mean, look, I think everything that John said, and before that, Councillor Hoskin, and also thank you for the update, Sarah, is completely true. If we allow the NHS to become a national hospital service, well, then we really are in trouble. Notwithstanding the fact that I think people out there do want some a better Royal Berks, more accessible, and with better buildings, that's for sure. So we have got under capacity, I think, of hospital beds in this area, but also nationally. But that shouldn't clearly be the focus. In your report, you're saying we're spending more on acute than the whole of those other services combined. And I suppose if my question would be, are we the only area doing this, or is this national? No, national. And it's the same really in adult social care, where I think 6 or 7% of people end up in a care home, yet the whole focus of conversations around adult social care are about care homes and people avoiding fees and goodness knows what else, when actually the real adult social care is people of all ages and needing good primary care in their community and in their support, because without that, well, then we have a massive problem again into the hospitals. So I suppose I'm making a statement, also was asking Sarah, you understand this, will the focus and the bob be to try and address that financial imbalance as much as you can to lobby, because I think that's really important.
Yes. So we are like, we're not a national outlier in terms of the proportion of funding that goes to different parts of the system. It is something that we're always looking at, and given our renewed focus on prevention and kind of proactive care, we absolutely need to be looking at how that is delivered and therefore where funding goes. I say funding, where resourcing is, because some of this might be actually taking some of the super specialist resourcing that's currently within the Royal Berks and enabling those teams to outreach more into the communities, to upskill, to share yeah. So it's not necessarily about always moving cash around the system. It's where have we got our highly skilled clinicians spending their time to the biggest benefit. So yes, we are looking at that.
Thank you, Chair. I came late. I've got to do a school pickup, so I've got to go. But thanks for everybody for that.
Thank you, Councillor Gittings, and thank you to Sarah for the report. So, apologies, Andy.
Yeah, thank you. I was just going, it was mentioned earlier in the presentations about the Community Wellness Outreach Project. I know it's a pilot and it's got pump priming from NHS England at the moment. I think when I spoke to Martin many months ago, even a year ago, there was this ambition of trying to demedicalize some of the sort of initial health issues that people have out in the community. And I hope that this project will, by being closer to the community, not in a medical setting, but in community settings. Yes, it involves an NHS health check, so it's about doing the basic checks, hopefully to pick up those preventable things that to give the better outcomes further down the line. But it will also give a chance for the community to be involved in looking at their health and their wellness in that safe space in the community, so that then they can look after themselves. They get signposted to how to look after self-care, how to look after your neighbour, how to look after each other in the community, and then using, even at that point, general practice as and when they've got an actual condition that needs medical care and ongoing support. So it's trying to make that low-level wellness and looking after yourself a demedicalised issue, rather than I'm feeling a bit poorly today, I'm going to go and talk to the GP, and then that can take up a lot of time when we're dealing with a lot of undifferentiated, just either it's often the social situation that's making things difficult for them, or there are potentially some mental health issues, which again, GPs can support when it's more severe, but low-level mental health, again, can be demedicalised and dealt with in the community. So I think that's the hope, my wish for this project, and hopefully it will be the building blocks of something more going forward. As John was saying, we need to be thinking about how do we get the prevention out in the community, so that then we don't go to the hospital for one, but also that we only use the GP practices and the rest of primary care for the conditions that actually need to be treated. Thank you.
Thank you, Andy. Right, I can't see any other hands raised. There's nobody. Thank you very much for the report, Sarah. Thank you. So if we're moving on now to agenda item 11, which is the Berkshire West Primary Care Alliance membership of the Health and Wellbeing Board. And Nikki is presenting.
Thank you, Chair. It's a procedural report, really. The Berkshire West CCG has been replaced by the Bob ICB, and the ICB has been reviewing its representatives on the boards. Dr. Chesky has stayed on as the ICB second representative whilst they were awaiting the decision, but they've now informed us that they only wish to take up one of the representative positions and won't be providing a clinical rep, but are recommending that the board co-opts a representative from the Berkshire West Primary Care Alliance and nominating Dr. Chesky to be that representative. Sarah is staying on as the ICB's rep, and Helen Clark, the deputy director, will be Sarah's name substitute. And the report sets out what the Berkshire West Primary Care Alliance is, and also notes that because Andy Chesky was the vice chair before, we wouldn't have a vice chair because they have to be an ICB rep. So it's proposing that you agree Sarah as the vice chair. Andy has just tabled us some information which, Andy, do you want to speak to it?
Thank you, Chair. Thank you, Nikki. Thank you for all your hard work in preparing the proposal paper. I'm just going to throw a little spanner in the works because the terminology of different organisations and representation in general practice can be confusing. So I'd like to offer my apologies first of all, but also offer some clarification of the names of GP organisations and their representative responsibilities. Okay, this is a little tutorial for you all. The Local Medical Committee, LMC, is the only body that has a statutory duty to represent GPs at a local level. The statutory duty was first enshrined in law in 1911 and has been included in the various NHS Acts over the recent past and is included in the Health and Social Care Act. GPs in Reading are represented by the chair of the Berkshire West LMC, part of the Berkshire, Buckinghamshire and Oxfordshire LMCs. The function of LMCs is to represent the interests of GPs and practices with the objective of optimising the terms and conditions, working environment and stability of all GPs, both individually and at a practice level. Berkshire West Primary Care Alliance is a provider organisation and GP federation that represents the interests of its member PCNs and practices. It has 4 directors elected to the board by its members when it was set up in June 2023, when the Berkshire West PCA was set up as a company. Its membership includes 34 practices from 14 PCNs across Berkshire West. In Reading, members include 13 practices from 6 PCNs. A GP federation is a collective group of GP practices across a set of geographical area with a common desire to work together at scale, sharing responsibility for the development and delivery of high quality patient-focused services closer to home for their local population. The Berkshire West GP Leadership Group, all right, are we all keeping up to date, is a group of GPs giving a strategic voice of general practice within the BOB ICB. They include GPs who are PCN clinical directors, LMC representatives, and GP Federation clinical leads. There are 3 GPLGs in BOB ICB in Buckinghamshire, Oxfordshire, and Berkshire West. The 4 Berkshire West GPLG clinical leads were elected in March 2023 following the votes from all 44 GP practices in Berkshire West, 18 of which are in Reading. Having clarified the various organisations, I would like to propose that the Berkshire West GPLG is the most appropriate representative body of general practice on the board. Its primary aim is to work with the BOB ICB and the rest of the integrated care system. It is best placed to support the board in delivery against the shared priorities set out in the Berkshire West Health and Wellbeing Strategy. So when we made the proposal initially on the paperwork, I was all enthusiastic that the Berkshire West PCA Primary Care Alliance would have full membership of all the Reading GPs, so would be able to have the full representative authority. Unfortunately, that is not the case. So we have a number of practices that have chosen not to join the alliance. So we've fallen back on the Berkshire West Leadership Group, who was voted in by all practices as being the most appropriate body to act as a representative. Being a member on the GP Leadership Group for Berkshire West, I will still stand as a potential representative of that group if the board wishes to accept me. Thank you.
Okay, thank you.
I hope that's clear.
Yeah, really. Yeah, that's great, especially on a Friday afternoon. Okay. So basically, I don't know if. Oh, John, we'll hand that over to you.
I think we could have done with having notice of that, really, and for it to have been circulated in advance. I mean, it has implications. We do need to digest what's being said there. I mean, I've had, I've worked with LMCs for between 30 and 40 years, and I recognise that in many ways they're a trade union, and we need to really be clear what it is we're wanting for the best here, in the spirit of fraternity and partnership.
Thank you, John. And Nikki wanted to speak.
Just to clarify that this appointment would be a co-option rather than a membership of the Health and Wellbeing Board. So it's a co-opted member, but it's somebody to come along and effectively join in with the meeting, but can't vote on anything. So there are only 8 because there's only one ICB rep. I think it's only 9 representatives who are actually voting members. So Andy wouldn't be a voting member anymore, like he used to be, if that makes any difference from what John was just saying.
Yeah, that's important, you see, isn't it? And it's important that we're able to digest the full situation.
Okay. So are we proposing that we postpone the decision? Are we? Yeah. Or Councillor Hoskin?
I'm not sure I've totally got my head around all the nuances of this. If we put it off to the next meeting, does that presumably I mean, it can still come along and we'll just take from there. It won't really make any difference, will it? And we'll, does that make sense? Take it to the next meeting?
The next meeting.
Yeah, and just, yeah.
Okay, so we're all agreed that can we circulate the yeah, you will circulate the document from Andy,
Yeah.
and then we'll delay the decision to the next meeting. Okay, thank you.
Chair,
Sorry,
did you
Andy.
want to agree for Sarah to be vice chair, because that doesn't depend on
Yes,
this?
okay. Are we all happy to agree that Sarah's vice chair? Yes, everybody's in agreement. Okay, thank you. And Andy, did you want to come back there?
No, thank you. I'm very happy for, I apologise for the late submission of the amendment. I'm very happy for our work with Nikki to amend the proposal for the next meeting with the correct nomenclature. Thank you.
Okay then, so we're agreed that Sarah is vice chair and we're going to delay the amendment until the next meeting. Okay, well, thank you very much, everybody. And moving on to the next agenda item, which is the date of the next meeting, which is the 15th of March. So thank you very much to everybody for attending, and yeah, have a lovely weekend. Thank you. Bye. Bye.
Bye.
Thank you, everyone. Bye to everybody online. Bye.